e ngā reo, e ngā mana, e ngā kārangatanga maha, tēnā koutou, kia ora tātou katoa. I extend to you my warmest greetings, and I would like to acknowledge the Aboriginal and Torres Strait Islander people who are the traditional custodians of the land where this symposium is being held. I would also like to pay my respects to elders past and present of the Aboriginal and Torres Strait Island nations, and I extend that respect to other Indigenous people who are present or watching today. It's an absolute privilege to be speaking with you all today as the Director of New Zealand's first Suicide Prevention Office, which was opened in November 2019. I thought I'd take you through the journey we've been on over the past 18 months and talk you through some of the early lessons we've been afforded during this process. But before I do that, I think it's important just to set the scene. Every year in New Zealand, hundreds of people die by suicide. Over the last few years, the suicide rate in this country has averaged 13 deaths per 100,000 people. The youth suicide rate in New Zealand is shockingly high. The provisional rate for deaths by suicide of those between the ages of 15 and 19 was 18 deaths per 100,000 people for the year ended 30 June 2020. That statistic places New Zealand's youth suicide rate among the worst in the developed world. Further, our Maori communities are severely impacted by suicide. In the last year, the provisional rate of suicide deaths amongst Maori was 20 per 100,000, much higher than that of the New Zealand European population. These statistics paint a stark picture, and the government moved to address the deeply troubling issue in 2018. In January of that year, our government established an inquiry into mental health and addiction. The inquiry's terms of reference were set by the government, and areas of focus included suicide prevention, as well as support for those who were close to someone who had taken their own life. The inquiry panel was tasked with hearing the voices of the community, including the voices of people with lived experience of mental health and addiction challenges, and of people affected by suicide. Following extensive consultation and engagement, which included numerous community meetings across the country and the receipt of hundreds of written submissions, the inquiry panel released He Ara Oranga, report of the government inquiry into mental health and addiction in late November 2018. A key message from the thousands of those who engaged with the inquiry was the need for our approach to mental health and addiction to be wellbeing focused. Many submissions spoke to what was needed for suicide prevention and to better support those bereaved by suicide. In the report itself, it was stated that suicide prevention was seen as a societal response, not simply a health issue. Strengthening protective factors is not a role that is best led by health services alone, but by whānau, to families, hapu, to sub-tribes, and iwi, which are tribes, Pacific peoples, rainbow and other communities, university and tertiary providers, schools and early childhood education providers, workplaces, sports groups, faith communities, social services, organisations that support positive parenting, youth development and positive ageing, and a range of other community sectors. In short, strengthening protective factors needs to be contributed to by everyone. He Ara Oranga concluded with 40 recommendations, and 4 of these recommendations were specifically related to suicide prevention. It was recommended to the government that they urgently complete the National Suicide Prevention Strategy and Implementation Plan and ensure that the strategy is supported by significantly increased resources for suicide prevention and postvention. It was recommended that the government set a target of a 20% reduction in suicide rates by 2030. it was recommended that the government establish a suicide prevention office to provide stronger and sustained leadership on action to prevent suicide. And finally, it was recommended that the government direct a review of processes for investigating deaths by suicide. The government accepted 3 out of 4 of these recommendations, which was consistent with the urgent call for action in He Araoranga. However, the government decided not to set a percentage target for the reduction of suicide rates and instead set a goal of no suicide, acknowledging that every life matters and one death by suicide is one death too many. In September 2019, the government announced the completion of New Zealand's Suicide Prevention Strategy and Action Plan. Every Life Matters, He Tapu Te Oranga o Ia Tangata. It's a suicide prevention strategy for 10 years from 2019, and it's a suicide prevention action plan for 5 years from 2019 to 2024. We refer to this document in the short form as He Tapu Te Oranga, which translates as every life is sacred. He Tapu Te Oranga is part of the broader transformation of the mental health and addiction system to ensure it is accessible and supports people effectively. Our strategy outlines a clear vision that every life matters and that by working together we can achieve a future where there is no suicide in New Zealand. We believe that achieving this vision requires us to take a new approach to suicide prevention, one that is grounded in well-being and one that addresses the wide range of risk factors associated with suicidal distress and suicidal behaviour. Broadly speaking, our strategy's framework consists of the vision I've spoken of, where we can achieve a future where there is no suicide in New Zealand. We expect the outcomes of this strategy to be a reduced suicide rate in this country and well-being for all. We have focus areas which focus on building a strong system that supports well-being and responds to people's needs. And there are 4 main areas or focus areas in terms of that system, including national leadership, using evidence to make a difference, developing the suicide prevention workforce, and evaluating and monitoring the progress being made. The strategy also conceives of suicide prevention as being or as constituting a continuum from promotion of well-being at one end through to prevention and response to suicidal distress, through to intervention, where the focus is on responding to suicidal behaviour, and then postvention, which is the support and response following a suicide. Significantly, our strategy is underpinned by a notion of collective ownership. As I highlighted earlier, one of the outcomes of He Araoranga, or one of the findings in He Araoranga, was that everybody has a role to play in promoting well-being and thus preventing suicide. So that's carried on, that theme is carried on through our strategy with collective ownership underpinning everything that we do. In accepting the recommendations from He Araoranga, the government agreed to establish a suicide prevention office. It was proposed that the office would provide a clear locus of responsibility within central government for suicide prevention and provide whole of government leadership and coordination of suicide prevention and implementation of the Suicide Prevention Action Plan. I was appointed Director of the Suicide Prevention Office, and I took up this appointment in November 2019, and the office itself was formally opened a month later in late November. Given that this is where I enter the picture, and having set sort of the scene or the background, I think it's timely to introduce myself, as my personal and professional experiences inform the perspectives that I bring to this position. I'm a first-generation New Zealander of Thai and New Zealand European descent. The photo now is I guess a nod to my Thai heritage. That photo is taken in the region of Thailand that my family is originally from. I have a background in research, policy and teaching, in sociology and in Maori studies, and then I practiced law for several years before being appointed a coroner in 2007. I held that role for 12 years before taking up the position of Director of the Suicide Prevention Office. As a coroner, I reviewed and investigated literally hundreds of suicides. I believed that my responsibility as a coroner was to understand and explain the social context of the suicide to the family and friends of the person who had died. I considered this important, one, to try and help the family understand and come to terms with why their loved one had died by suicide. It wasn't a case of being able to give them the reason, but I think that being able to explain the context and the possible reasons helped increase understanding and led to quite useful conversations around how suicide risk might be reduced. Over the years that I was a coroner, several fundamental premises became quite clear to me. I think the first was that suicide is virtually impossible to predict. I recognise that this is well known by those who work in the field of risk assessment, but I don't think that it's well understood by people outside of that workforce. And what I mean by that is that risk assessment suicide risk is really dynamic and can really change within hours or from day to day. And so while you can have a risk assessment, that doesn't predict the outcome. And I think it was not well understood, not by myself at the start of my career as a coroner, and not by lots of people who are grappling with the aftermath of suicides. It also became clear to me that suicidal distress arises from a range of risk factors, and that these can be overwhelming in the absence of sufficient protective factors in an individual's life. And finally, I came to see that mental health services and crisis services only have a small part to play in suicide prevention. I acknowledge that the part that they play is really important, but it is only a small part in the continuum of suicide prevention. So for me, agreeing to lead the Suicide Prevention Office was an opportunity to contribute to what I see as being the absolute imperative of preventing suicide in Aotearoa, New Zealand. I think that the seriousness with which we take the issue of suicide is reflected in the establishment of the office. And when I took up this role, I was left in no doubt about the weight of expectation on the office and I guess on myself as the director. When I reflect on the past 18 months, I feel simultaneously proud about what we have been able to achieve in a relatively short time, but also somewhat anxious and overwhelmed from time to time about the breadth and depth of the work yet to be done. We literally did set off from a standing start when the office opened. I took over 2 staff from the Mental Health and Addictions Directorate at the Ministry of Health, who had previously worked in the suicide prevention area. I also took over several contracts that were in place to do with suicide prevention and some contract negotiations that were already underway. I think it's important to stress that suicide prevention was not a new endeavour within the Ministry of Health, and I think to suggest otherwise would belittle the really important work that had been done in the past. The Ministry of Health had overseen the establishment of and provided guidance to a suicide prevention workforce made up of suicide prevention coordinators that we find in almost every district health board in this country. The Ministry of Health also funded national Māori and Pacific suicide prevention training programs delivered by key agencies, Te Rau Ora, in respect of the Māori suicide prevention program, and LAVAR in respect of the Pacific suicide prevention training program. And importantly, He Tapu Te Oranga was drafted by the Ministry of Health prior to both my appointment and the opening of the office. Significantly, however, He Tapu Te Oranga and the establishment of the office certainly signalled a sea change in the way the issues are being framed, and a clear commitment on the part of government to accord suicide prevention considerably higher priority than previously. The first thing I did when the office was opened was establish a Māori expert advisory group, which was chaired in its first year by Sir Mason Dury. Sir Mason was a member of the He Ara Oranga Inquiry Panel and has decades of experience in mental health and Māori wellbeing. This group provided expert high-level strategic advice, support and guidance to me and to the office on matters relating to Māori suicide prevention and the implementation of He Tapu Te Oranga. They were a vital part of setting, I guess, the foundations and principles to guide the office's work. Their contribution has been significant in setting key messages and also in advising the approach that might be taken to suicide prevention, which is in fact an approach that is relevant to all population groups. I think it's important to share some of our key messages as they reflect what we understand suicide prevention to involve. People who die by suicide are almost always acutely distressed, but are not necessarily mentally ill. The reasons that people take their own lives are complex and informed by factors that accumulate over a lifetime. Suicide risk is associated with inequity, social determinants, and experiences of trauma. New Zealand's suicide rate will not come down until inequity, trauma, and adverse childhood experiences are addressed at a societal level. People can be effectively supported through suicidal distress, especially when support is readily accessible. There is no one-size-fits-all in suicide prevention, and different cultural and ethnic groups must be supported and empowered to design and deliver their own approaches to suicide prevention. And finally, strong, healthy, connected whānau, families and communities are the most important protective factors against suicide. The other significant strategic advice given by the expert advisory group related to the approach to be taken to Māori suicide prevention. In terms of our Treaty of Waitangi obligations and equity, and in view of the disproportionately high suicide rates of Māori, and in particular of Māori youth, Māori suicide prevention is a priority for us. The advisory group reached the view that the role of the office is to provide national support and coordination for regionally or community-led approaches to suicide prevention. The challenge now for the office is to understand how we advance that nationally, while acknowledging that hapu and iwi, sub-tribes and tribes, are differently led, organised and structured. They each face different realities, they have different histories and different resources and capabilities available to them. So it's certainly not the case that we as the office can say, well, this is our approach and now it's over to you. Rather, we have to work alongside different communities, different iwi, different hapu, providing support as is sought. And in fact, this is not unlike the challenge we face with the major suicide prevention workforce that we have, which are the suicide prevention coordinators and district health boards. This workforce is a backbone of suicide prevention at a regional level, but the coordinators don't work for the office directly, And so this leads to significant diversity in the way the roles are structured nationally. So this is not necessarily a bad thing. And, we are interested in regionally specific responses and approaches that suit, the communities being served. But what we think is important is to somehow ensure alignment nationally with our suicide prevention strategy and action plan. So we're well into a process of working our way through the issues that arise in this context. And I have to say that one of the parts of my role that I enjoy the most is engaging with those who are working on the ground, learning about what they do and the challenges they face and the opportunities that they see, and talking with them about how the office might be helpful to them. I think it's useful also to share with you some of the other initiatives or achievements of the office in the past sort of 18 months. We were able to establish the Suicide Bereaved Response Service, Ao Ake Te Rā, which provides free counselling for people bereaved by suicide. This is available online, and face-to-face services are being rolled out nationally. We expanded the Family and Whānau Suicide Prevention Information Service to improve the information available for families and whānau. This service provides support to people across the country by enabling them to access a range of free resources on matters such as how to talk to young people about suicide. And it will also involve or enable the development of new resources. The office funded additional suicide postvention capacity in all 20 district health boards. And the office also worked in partnership with the Broadcasting Standards Authority to engage with media and commence development of revised media guidelines for suicide reporting to help support responsible discussion on and depiction of suicide across media and social media. We also commissioned a review of the suicide prevention sector and regional and community level suicide prevention services and resources. The findings of that review provide us with good information about how the suicide prevention sector might be more effectively structured. And we're looking at how we can implement the recommendations of that review. Reflecting on our first 18 months, I think that the biggest battle or challenge that we have had has been pushing back against the predominant public narrative that suicide prevention is about provision of services, and the idea that if everyone just had access to services, our suicide rates would decline. There's no doubt that accessible support services and mental health services are important. And I note that there is an enormous program of work underway here in New Zealand that is aimed specifically at increasing the range and availability of services and supports for those with mild to moderate need. However, the healthy and connected families and communities that we see as being the strongest protective factors against suicide are not born of services. They will arise when fundamental needs are met. The need for sufficient income, for stable housing, for personal safety, for a sense of belonging and acceptance. The social determinants of poor health and poor outcomes need to be addressed. And equally, the social determinants of good health outcomes are also significant contributors to suicide prevention. And a lot of those determinants are not within the purview of the health sector. So consistently with our belief in the importance to suicide prevention of strong families and communities, a significant proportion of our funding is committed to a Maori Suicide Prevention Community Fund and a Pacific Suicide Prevention Community Fund, with other community funds being considered. The point of these two funds has been to build community strength as a protective factor amongst Māori and Pacific communities, and also to build community knowledge and capacity to respond to suicidal distress. Importantly, these funds are both administered by agencies that are national leaders in suicide prevention, Te Ora with respect to Māori suicide prevention, and Lavar with respect to Pacific suicide prevention. In their first year, a total of 92 initiatives were funded across both funds, supporting Māori whānau, families, hapu, subtribes, and iwi tribes, and Pacific families and communities across the country to develop solutions to prevent suicide. Some of the initiatives funded included wānanga, which are like educational forums or seminars, to build inclusive Māori communities, strengthen resilience and support whānau living with grief and loss, workshops for rangatahi, young people, and Pacific youth, a digital application for Pacific youth, and a Pacific youth peer mentoring program. And I note that a number of the initiatives funded across both funds targeted youth and men, both of which are high-risk populations. So, I guess as this draws to a close, I look back and I think that much has been done, and we have laid a strong foundation for the work that is ahead of us. I think that we're in a critical stage of working out what national leadership means in practice. And if there was a second big lesson for me, it's been that there is a massive chasm between what seems like a good idea, and which is in fact a good idea, but the chasm exists between the theory and the operations. So operationalising the approach we want to take, is a tremendous challenge. The diversity of community and capacity and need across our small country has been a real eye-opener, and it's exciting to be working our way through what nationally coordinated, regionally or community-led responses and approaches to suicide prevention might look like. I do stress that we know that suicide prevention is complex and multifaceted, and that there are no quick fixes or easy answers. We are working across the breadth of the suicide prevention continuum, but we do believe that if there is to be a fundamental and sustained reduction in our suicide rate, we need to build strong families and communities. I'd like to share now with you the vision of someone who's walking the talk and whose work is completely on point in terms of being a community-led approach to wellbeing and thus to suicide prevention.
The suicide rate in New Zealand has been high for a very long time. And I think it's a setup we got in this country. Too much of our focus is on a medical model. I think that we should use a model that's more inclusive of how Maori think, at least, as an Indigenous person.
It's a big issue. Some people, for example, define Maori by their disparities and disadvantage. That's not a very good definition. The other way of looking at it is you define people by their potential, and certainly that's what you see in Zach's programs. It's not about health or unemployment or sickness or bad education, it's about pulling all this together. So one of the big challenges, I think, for us as a country is how to get a much more integrated approach to wellness and well-being.
Very humble, my son, he's very humble. Anybody will tell you that. But he's very clever. And he's very funny. I like because he's witty too, He's not a boring academic, He's got some real gems about him.
He's got quite a good balance between telling people what to do and listening to what people want to do. And he seems to balance that quite nicely in a way that many others can't do.
And the operation is to have them live like we used to in the past. The PAR is a place where people live together and work together. So right now we've just got the basis of a road, some houses going up, and a wellbeing centre, a whare oranga, a place where people can work together around their wellbeing.
His work is about wellness for young people. And so that's hugely important in an environment where very often the people he's working with might never otherwise experience the notion of wellness. So I think the work he's doing is groundbreaking. Key to it, though, is leadership. And Zach has a type of leadership which makes it work, which holds it together. Not everyone has that leadership ability, but that's the key to this. And I think in that sense, the people he's working with, the young people, he's helping them to become leaders as well. So this whole question of leadership is a critical part of the Tai Tumu Trust.
Well, I think, you know, I've been given a talent to work on people's emotions. And it's an emotional journey. There's always an emotional journey. And I think if you can touch not only their hearts, but people's minds, you're moving in the right direction.
Otherwise we dwell on the disparity and we dwell on how bad it is and miss the potential that we've got never gets expressed. That's why Zach's program is so important. It's about helping young people realise their own potential despite whatever might have happened in the past.
I don't need to know every detail about you, but I just need to know that we can engage first. I mean, it might be a cup of tea on the open fire. It could be that you're going to help with our nursery or some of our homes here, you know. But you're always going to have somebody that's going to be supporting and talking to you during your stay with us.
There is so much amazing work being done in small communities up and down the country. The office is in the process of developing a digital platform where we can share these, because we think it's really important to demonstrate their value and also to give other people ideas and inspiration about what they might do, you know, in their own communities or spheres of influence. Sometimes this job and the road ahead feels underwhelming, and in those moments it's really helpful for me to remind myself of the adage about long journeys being taken a step at a time. And it's also helpful for me to call to mind the many, many people working to contribute to suicide prevention in this country. The work is being done in many ways at many different levels of society and across many different sectors. I do believe we can achieve our goal of a New Zealand where there is no suicide, but it will take us some time and it will take courage, and it will take an understanding that suicide prevention is not primarily the domain of mental health services. To conclude, I take you to the Whakatauki that is in our in He Tapu Tuaranga, our strategy. Tiro he te pai whānui, tuatu I te pō. Tūramarama ki te ora, whakamaua kia tīna. See the broad horizon beyond the darkness. Hold on to life. Thank you for your time. I wish you well.